الزملاء والأخوة الأعزاء، أسعد الله صباحكم. نرحب بكم بالقمة الأولى لأمراض القلب الاستقلابية. يعني أنا الكلمة هذه أنا بشكر الدكتور رائد عقل اللي ترجم لي إياها بصراحة. دكتور رائد موجود مش هيك؟ اللي هو CardioMetabolic Summit. راح نناقش عدة مواضيع اليوم متعلقة بأمراض السمنة والقلب، ارتفاع دهنيات الدم، أمراض السكري والقلب، واعتلال عضلات القلب. احنا عندنا القمة الثانية راح تكون بهايبرتنشن سمت، راح تكون ب17/5، وعندنا PCI مينا راح تكون بتاريخ 6/10. بس بحب أخبركم عندنا 100 طبيب قلب سجلوا من العراق، 100 طبيب قلب من العراق، وعندنا أكثر من 20 طبيب من مصر. بلشنا الآن يعني في عندنا إقبال كبير على PCI مينا. بحب أنا أشكر جمعية القلب الأردنية ممثلة برئيسها الدكتور عبدالفتاح أبو حويلة على التنسيق الكامل ما بين ICIG مجموعة أطباء القلب التداخلية وجمعية القلب الأردنية. إحنا عملنا موحد بكل السمتس، بكل المؤتمرات اللي عم نعملها. فبنحييكم وبنحيي كل الأطباء الموجودين، إن كانوا من القطاع العام، كانوا من القطاع الخاص، من الخدمات الطبية. وبنحيي الدكتور يوسف، الأستاذ الدكتور يوسف القصوص، الأب الروحي لأطباء القلب في الأردن. أهلا وسهلا فيك يا دكتور يوسف. والدكتور يوسف هو كمان الرئيس الفخري لهذه القمة، بنرحب فيه مرة ثانية. يعني تصور لو أنت مش موجود اليوم الصبحيات الشعور بكون داون، هسا أب. فتفضل يا باشا.
أسعد الله صباحكم وطاب الصباح بكم. شكرا محمود، دائما كرمنا. أنا أشكر المجموعة القلب التداخلي الإبداعي برعاية جمعية أمراض القلب على هذا الإنجاز الحقيقة، وأشكرك على الدعوة، وبهنيكم على هذه الندوة الثرية بموضوعاتها ومتلقيها وملقيها. حقيقة ثروة، ندوة مهمة جدا وموضوعاتها مهمة. أنا قلت بس بدي to highlight the prevalence of cardiometabolic syndrome in Jordan and present all original papers from Jordan، من جامعة علوم التكنولوجيا، من مش أنا اللي كاتبهم، من مركز الغدد الصماء، كلهم دراسات أردنية بحتة منشورة في مجلات عالمية. The first paper published June 6, 2020, an alarmingly high and increasing prevalence of obesity in Jordan. According to the IDF, the National Diabetic Federation, the age standardized prevalence of obesity was 60.4 among men and 75.6% among women. The age-adjusted odds of obesity in 2017 were approximately twice those in 29 in men and women. Prevalence of dyslipidemia. The prevalence rate of hypercholesterolemia, hypertriglyceridemia, high LDL, and low HDL were 44% hypercholesterolemia, 41.9% hypertriglycemia, 75.9% high LDL, and HDL 59 low. طبعا tobacco وobesity 59.5% HDL. Hypercholesterolemia in Jordan almost doubled from 23% in 1994 to 44.3% in 2017. Hypertension in Jordan, prevalence and awareness control. The age standardized prevalence was 33.8% among men and 29.4% among women. Of those, من الhypertensive, 57.7% of men and 62.5% of women were aware of hypertension. الباقي ما حد بيعرف انه عندهم ضغط. تعرف it's a silent killer. Only 30.7% of men and 35.1% of women who were on treatment had their pressure controlled. يعني هاي مشكلة بالهايبرتنشن بالمناسبة. القاتل الكامن. يعني بكون عنده ضغط ما بكونش عارف باخذ الدواء مش كنترولد. يعني عندنا مشكلة دائما في الهايبرتنشن. Metabolic syndrome among adults in Jordan. كل research كله Jordan. According to the IDF criteria, the prevalence of metabolic syndrome was 48.2%, 52.9% among women, and 46.2% among men, and among women, 46%. The prevalence rate of metabolic syndrome was significantly higher in 2017, for 44.7% in men and 44.5% in women. In 2019, and قبل 3 years survey, 34.6% in men and 39.8% in women. Characterizing the type of diabetes, type 2 diabetes mellitus in Jordan up to 2050. Diabetes mellitus type 2 prevalence was 14% in 1990 in Jordan, 16% in 2020, projected 20.6% in 2050. The total predicted number of diabetes mellitus cases were around 220,000 in 1990, round finger هذا فيها قصور, and 700,000 in 2020. DM epidemic is a global public health concern and the 7th leading cause of death worldwide. The Middle East and North Africa, MENA, has the 2nd highest diabetes mellitus prevalence worldwide, with 54.9 million adults estimated to be living with DM. أنا المعلومة الثانية China ما كنتش عارفها. I have to look. China is the first in the world. China is the country of the highest number of diabetics worldwide, with around 141 million people suffering from the disease. يعني China, أنا أول مرة بعرف إنه China the best, the highest. Estimated cost of diabetes mellitus, hypertension, dyslipidemia. موضوعنا اليوم يعني قديش بيكلف؟ البادجت واليير والكوست. في 2004 هاي البادجت قدامكم 2 بليون 22% كان البرسنتج. 2010 19, 2012 20, 2014 22.1.6 بليون في سنة 2014 كان الكوست من الموازنة. Global economic burden of diabetes and its complication. The cost of diabetes mellitus worldwide in 2015 was $1.3 trillion, or 1.8% of the global gross domestic product. حقيقة diabetes is the most expensive disease to treat in many parts of the world. وشاكرين أعطيتونا الفرصة. شاكرين.
احنا بس نسينا او بيحكوا سقط سهوا. انا بدي احكي الدكتور الحبيب دكتور سعد جابر، يعني من الاطباء اللي بيحترموه مش فقط في القلب ولا في الطب العام ولا الشارع الاردني. اسمك صار معروف يعني ترند. بنحييك وبنحيي وجودك معنا، ودائما داعم لجمعية أطباء القلب وداعم للICIG، ونأمل تكون معنا في كل مؤتمراتنا. تفضل دكتور عبد الفتاح أبو حويلة. بس بحب أحكي لكم احنا رح نبدأ إن شاء الله الساعة 10:30، بس بدنا التزام بالوقت. المحاضرات 15 minutes بعدين discussion.
بسم الله الرحمن الرحيم. أصحاب المعالي والعطوفة، الإخوة والأخوات الحضور الكرام، الصراحة أنا كنت محضر كلمة، بس أرقام الدكتور الباشا يوسف القصوص كنت أوريدي أنا مفكر بموضوع معين على موضوع جمعية القلب الأردنية، لكن الأرقام مرعبة ومخيفة. أنا رأيي، وإن شاء الله نتفق جميعا على هذا الموضوع، إنه دور الجمعية أو دور أطباء القلب وأطباء جراحة القلب ليس فقط إجراء قسطرة أو عملية قلب مفتوح. We should target patients at the community level. We should increase awareness. يكون لنا دور إحنا فعال in prevention, education and awareness. فهاي إن شاء الله راح تكون الميشن القادمة للجمعية القادمة، وراح نسعى جميعا إنه نحقق هذا الهدف. طبعا أنا بشكر الدكتور محمود كثير على organizing this CardioMetabolic Summit، وهي الأولى هذا discussing هذا الissues complications of cardiometabolic disorders and also prevention of cardiometabolic disorders. فهاي راح تعطينا كمان هنت، وإن شاء الله نصير إنه نحط guidelines إحنا في الموضوع هذا للجوردانيانز، لأنه أرقامنا إحنا أكيد تختلف عن غيرنا، فبالتالي إنه يكون في عندنا our own guidelines. فهذه المشن الثانية للجمعية القادمة إن شاء الله، إنه increase awareness, trying to put our local guidelines in improving our patients' medical care and cardiac care. طبعا نجاح الصمت هذه الصراحة تم مثل ما تفضل الدكتور محمود بتعاون تام بين وتنسيق تام وهارموني بين الجمعية وأعضائها وبين الدكتور محمود وأعضاء الهيئة الإدارية للICIG. فالشكر يعني جزيل لهذه المجموعة على نشاطاتهم المستمرة. طبعا في آخر الكلام إنه إحنا نشكر الشركات الداعمة لهذه المشاريع العلمية والثقافية، وإن شاء الله راح تصير نشاطات مجتمعية بدي أسميها للمرات القادمة. وبديش أطيل عليكم كثير في الكلام. في نهاية الأمر إنه الله يحفظ الأردن ويحفظ سيدنا على رأسنا دائما إحنا إن شاء الله، ويحفظ الأمن والأمان في المملكة الأردنية الهاشمية. وشكرا جميعا لحضوركم.
We have 4 lectures in the first session. Our first speaker is Dr. Hadi Abu-Hantash. He's our colleague, teacher, well known in the interventional community in Jordan. He will talk to us about lipid guidelines, concepts, and controversies. Please welcome Dr. Hadi.
Thank you. So I was given the task, I don't know how they came up with this task, by the way, of the ACC-AHA cholesterol guidelines, concepts, and controversies to decrease the incidence of atherosclerotic cardiovascular disease in the future. Well, I started my presentation with this slide. Why? Concepts and controversies. We know from the older data of using statins to reduce cardiovascular events. Up to 2008, when you look at the Jupiter on the right side here, which was published in 2008 on rosuvastatin as a primary prevention trial, what do we see? We see that we are decreasing the relative risk of cardiovascular disease So what's happening that the relative risk reduction with the introduction of statins 20 years ago, we got somewhere. You decrease it anywhere from 24%, and with Jupiter, we went up to 44%. But look at this in the down there. Down there, you can see that we are not doing very well. لا بالpointer head ولا بالpointer head. خليني أنا أشتغل زي ما بدي معناته. The residual risk is still very high. And that's we are lacking. However, from 2008 until now, we have some improvement in treating lipids and management. Look at this slide. It's a kind of scary that if a patient gets a myocardial infarction and you follow them up to 1 year, what happens there at 1 year? Almost 20% of the patients, 1 out of 5, will have a myocardial infarction again, and or they will have a PCI like a stent or a coronary artery bypass surgery. Scary. It's really scary when you think about it. So where are we now? Did we improve? This is from the European Guidelines 2019. Yes, we did. When you plot the major vascular events on the perpendicular line on the left and the LDL cholesterol reduction by millimole on the horizontal line, and you look at the 5-year risk of the major vascular events on the right side, what's the message of this? Simple message. Patients at the highest risk at 5 years, you manage to get their LDL to the lowest level, they will get the best benefit out of LDL reduction. And that's where we should work hard in preventing more cardiovascular events. The American College and the American Heart introduced some 10 years ago the concept that all statins are not the same. We have high intensity, moderate intensity, low intensity. We as cardiologists, I don't think any of us uses the low intensity anymore. We don't use it probably as frequently as you might think. However, most of us do use the high intensity, which gets the LDL to more than 50% reduction of the baseline, or moderate intensity. The only two which are shown time and time again to do that are atorvastatin 80 milligram, rosuvastatin 20. Atorva 40 was supported by only one randomized trial, and the rosuva the same, the 40 milligram. So the most commonly used is 80 atorva and 20 rosuva. Now, we did not stop there to decrease the gap on the residual risk in patients who have atherosclerotic cardiovascular disease. We did very well. When you look at the bottom line there, using a PCSK inhibitor plus high-intensity statin can get you to an LDL reduction of 85%. That's incredible. يعني قبل 10 سنين ما حدش كان يتخيل إنه هذا الإشي يصير أصلاً. That's incredible. But the problem is the PCSK9s are expensive. They're subcutaneous injections. You have to take them twice a month. So it's not an easy task to offer to everybody in the public. And that's why the high-intensity statin plus ezetimibe became the most popular in terms of reduction of LDL and reaching the goal, which can get you down to 65% of the LDL from baseline. So we're doing fine. The future is still up there, and it's going to work for us, I think. You all know about inclisiran. I think there's a lecture which will be given about that. Inclisiran is a small interference RNA type of PCSK9 inhibitor. When you use it twice a year. Twice a year. That's a dream come true. Subcutaneously, a fixed dose for everybody, doesn't matter what the weight, etc. is, and you can get to the mean LDL reduction of 50%, almost 51%. But the bottom line about this, please, this is not a medicine to use as an alternative to statin and ezetimibe. It's used on top of this treatment. So please do not get the wrong message. So when you get the inclisiran in the market, it's not made for somebody who has myalgias from statin. No, it's not. The other indication is, of course, high-risk patients, atherosclerotic cardiovascular disease patients with established disease, and of course the heterozygous familial hyperlipidemic patients. Triglycerides, we also have a good improvement in how we treat them. The isosapent ethyl, which is a form of EPA, omega-3, what is it? It was in the reduced trial showed beyond doubt that in the high-risk patients, the patients who were given Vascepa, it's called Vascepa, on top of the treatment of statins, on top, it's not an alternative, they do have a better outcome. And in the guidelines, the European, it's a 2A recommendation. The fenofibrate, bezafibrate, please remember that they fill off our day-to-day fashion use for a lot of good reasons. We still use them, sometimes for primary prevention, sometimes for high-risk patients, but be aware it's only a class 2B recommendation. Another concept which came out is, I talked about the first concept, the high dose intensity statins plus non-statins to reduce to the maximum LDL level. The duration of a treatment is very important. When you look at this figure, what do you notice? You notice that the patients who were maintained on a statin therapy by guidelines and by randomized data, more than 4 years of treatment, they get the best proportion of reduction in major vascular events. So the message and the concept is simple. You use the highest dose available to you, you combine it with a non-statin, and you go for a long period of time. Now, the guidelines in 2018-19, the ACC-HA, I don't want to spend time on this. However, they were nice enough to make it simpler for us. But remember something, what do you notice in the guidelines? 40 to 75 years old, 40 to 75 years old. Keep that in your brain all the time. Why are they putting this? Because that's where the bulk of the evidence is. The bulk of the evidence is between 40 and 75. Above 75, there are some unanswered questions. In terms of primary prevention, the ACC-HA outlined to us, let me just show you the ones in green for primary prevention. When do you must treat patients on statin as a primary prevention? If the LDL is 190 or more, irrespective of your risk, you treat with a statin. If the patient has a risk which you calculate of 75 to 20, we know above 20 it's a very high risk, then those patients have to be put on moderate intensity for sure. And the ones who are at high risk, who are already established, they must be treated with the highest intensity. And that's the class 1 treatment. Now, for primary preventive purposes, the risk of above 20, we know it's almost equivalent to atherosclerosis for those patients. Secondary prevention, the patients who have already evidence of atherosclerotic cardiovascular disease. Everybody has to be on lifestyle, gym, riyada, diet, etc. However, look at where the class 1A recommendations are. Below 75 years old, you use high intensity for those patients with established ASCVD. And when they are a very high risk, definitely use the high intensity. However, when you think that you did not reach the goal, you want to add a PCSK9, the guidelines clearly tell you, go to ezetimibe first. It's money, it's important because the PCSK9s are very, very expensive. So remember, before PCSK9, the patient has to be on a combined treatment of statin and ezetimibe. The ACC-HA also introduced the risk profile of patients, very high risk, ASCVDs. Remember, somebody who has an acute coronary syndrome, prior myocardial infarction, prior ischemic stroke, symptomatic peripheral arterial disease, 2 of them بكفوا عشان الواحد يكون very high ASCVD risk patients. إذا في واحدة, you need another 2 of the ones listed to make them high risk conditions. One concept which was introduced also by the American College and the European Society, which I think we have to be aware of, There's a difference when they use these two terms in the guideline, which are published, the goals. The goal is the LDL lowering in response to therapy is defined by percentage response by the Americans. The threshold is a specific value of LDL or non-HDL at or above which clinicians should consider starting intensifying therapy. So they are not interchangeable terminologies. So what's the difference across the Atlantic in the guidelines? Simple. The American College and the American Heart made it, I think, a bit simple. You must use, for those patients at the very high risk or established CVD, a medicine, high-intensity statin, probably with the ezetimibe, to reach 50% or more where the LDL was started. The European Society agrees with that, but they put for you goals, numbers, 70, 55, 40. The Americans don't have that. They don't have the goal. The goal is the 50% plus. However, if you use the 50% plus, the patient comes with an LDL above 70, that's not a goal size, it's more threshold, then you add an non-statin. And if you don't reach 55, then you think about PCSK9 or hopefully inclisiran in the future. Now, patients who are intermediate risk, they need enhancers. The ASCVD risk enhancers by the Americans, they are relatively close to the risk modifiers by the Europeans. So I don't want to dwell on those. Let me spend the last 3 minutes, Mahmoud. I'm on time, Mahmoud, I'm doing fine. The last 3 minutes on calcium scoring in patients in terms of using them to treat patients with ASCVD prevention. Please, I want to stress this point. When do you want to use a calcium score? I'll show you who are the best patients. But remember, the value of the calcium score is to tell you whether you need to treat patients with a statin. But you don't get any value of your money إذا طلع عندك الكالسيوم score 0 and the patient is non-diabetic. I'm sorry, if the patient is diabetic or a cigarette smoker or has a family history. So please don't order them for a diabetic patient. It makes no sense if you are looking to use statin. And remember, the 40 to 75, you have to use a moderate statin therapy for those patients. These are the list of patients who will really benefit from calcium score, just not to dwell on this. الناس اللي خايفين ياخذوا statin, اللي سامعين عن الستاتين بالجرايد انه بيعمل side effects, الناس اللي هم they want to be convinced that it's beneficial for them. Let me finish by a run through of the European Society of Cardiology latest guidelines. In my opinion, this figure is probably the figure which perfected treatment of lipid in 2021-22 after the guidelines were published. Why is that? When you look at the perpendicular line, they put the target LDL. Remember, they look at targets. They look at targets, the Europeans. And they put the risk here. And you, according to the risk profile, you treat, you don't treat, you choose which intensity therapy. But let me leave you with this message. In secondary prevention for patients at very high risk, the LDL reduction of 50% or more, so they agree with the United States ACC/AHA, from baseline and it's not only, and an LDL goal of below 55 recommended. يعني إذا أعطيت لمريضك who you put a stent, the highest intensity statin which is tolerable, you added ezetimibe and you still at above 70. Those patients, they need the PCSK9 or probably in the future you can use inclisiran. What is more important is نفس المريض هذا اللي عنده atherosclerotic cardiovascular disease and you treat him to the guideline therapy goal. He is on highest intensity statin, ezetimibe, and probably PCSK9, and the patient comes back with an event. Your goal by the European Society should be below 40 in those patients. Below 40. An unimaginable number. لو حدا قبل 20 سنة قال لك نزل ال LDL قبل لتحت ال 40 كنت ضحكت عليه أكيد لأنه it's like nonsense كان قبل 20 سنة. Anyways, with that let me finish. Thank you. I was on time, Mahmoud.
Good morning, everyone. I would like to present discussion at the end, yeah? Okay. I would like to present Dr. Raed Aqel. He's a consultant interventional cardiologist, and he's going to talk us about heart failure guidelines on paper and in real. Dr. Raed.
Good morning, صباح الخير. شكرا دكتور سعد for the nice introduction. Chairman, panelist, اللجنة العلمية شكرا جزيلا. صباح الخير للجميع. حكيت للدكتور محمود إذا بقدر أحكي كخبير على الحرب الروسية الأوكرانية اليوم، قال لي لا بلاش خلينا to stick to the subject. For today I'm going to have 15 minutes with you, sharing with you some local work that we have done on heart failure guidelines on paper and reality, what we call the reality disconnect. So to start with, I have no conflict of interest and no financial support was received for this lecture. I wish. So let's start with congestive heart failure with reduced ejection fraction. The first question, what is the size of the problem in Jordan and in Palestine or in the Middle East? The answer to that, we do not know. The good news that we have our friends Mahmoud and Hadi are leading now a Jordan heart failure registry that will, or started already a few months ago, and that will be a good nucleus for all of us to move on from that. However, there's also some local data that I have been privileged to be part of that I'm going to share with you. So let's talk about the prevalence of heart failure in an area of the Middle East in a clinic of medicine and cardiology clinic. We looked at patients who presented with cardiovascular symptoms to a medicine cardiology clinic over a year. We have 1,220 patients in that year. All of them, again, are symptomatic. They have cardiovascular symptoms in the form of either chest pain, shortness of breath, fatigue, poor exercise tolerance, etc. We have 57% males and 43% females. Of those, the age distribution was mostly more than 40, around 70% of those population. And here is what we found. If you define lower ejection fraction than normal as 50 or less, 24% of that group of 1,220 patients that are symptomatic, they have lower ejection fraction than normal, 24%. That's a big number. Let me remind you with the international statistics that showed that between 2 and 10% of the general population in the Western Hemisphere, they will have heart failure with reduced ejection fraction. However, those population were asymptomatic. Now we have a patient who are symptomatic. Therefore, the numbers in the United States, if you take patients who are symptomatic, will be close to this number. Now, the age distribution, as all of us know, especially the ones who practice this, is the older you get, the higher chance you will get an ejection fraction below normal, reaching around 50%. Now, this is not within the scope of my lecture, but since the data is available, I want to share it with you that in those 1,220 symptomatic patients, 40% were diastolic dysfunction. We'll talk about that in a different time. Again, in diastolic dysfunction, the older you get, the higher chance you will be having a diastolic dysfunction. Passing real fast, this is not, again, my talk today, is about heart failure guidelines. We have the 4 pillars. In the old days, we were going in heart failure pillars or treatment protocol in a stepwise fashion over 4, 8, 12 weeks. Nowadays, it is a class 1A to start all of these together, and within 4 weeks, start your patient on the maximum medical management, namely beta blockers, SGLT2 inhibitors, RNA, and mineralocorticoid inhibitors. The question is, do we have data about how many of those patients they come to your clinic and they are compliant with these guidelines? In the Western Hemisphere, including in Australia, the qualifier registry showed that only 23% of those patients will be sticking to your prescription and will be under the adherence guidelines. Most of the patients will be a partial adherence, 55%, and those who will not follow any prescription, any guideline, were around a quarter of those patients. How about the compliance in Jordan? I think it's variable. It depends on the doctors, it depends on which setting you are working in. We are not sure about that, but this is why I'm going to share with you our local data here. So this is our first publication in 2019, where we looked at 100 patients with congestive heart failure, reduced ejection fraction, over a year of follow-up. Of those, 20% were having follow-up adherence according to protocol. Now, let me remind you that these patients were seen by 2 cardiologists, 3 internal medicine doctors, and they were followed monthly by a phone call and every 3 months by a physical visit. Despite of that, the compliance was not more than 20%. Most of the patients were in the 50% range, that they follow your prescription, but they are not really tight on it. They might skip some doses, decrease the dose, and so on and so forth. 30% of your patients, regardless of your phone calls and your follow-up, will not follow your guidelines. So what are the reasons for that? Somebody might blame the patients only. In fact, in the Western Hemisphere, only 20 to 50% of doctors follow the guidelines. So only 20 to 50% of the doctors will follow the guidelines, meaning it depends on your setting. If you are in an academic institution, most likely you will follow the guidelines, but if you are in a community or private clinic, you might not. So 20 to 50% of doctors will follow the guidelines. Patient factors. We have multiple patient factors that might result in the patient not following the guidelines or not following your prescription, namely the fatigue of taking a medication for a long time, the cost of the medication, the side effects, the education of the patient, the level of education, and so on and so forth. So the big question, do we accept partial adherence? Is there any evidence on morbidity? So again, in this 1-year follow-up, we showed that despite of 20% excellent adherence and 50% partial adherence, that the ejection fraction, or I'm sorry, the New York Heart Classification did improve by at least 1 grade regardless of your level of adherence. So if you tell the patient you take 100 milligram of LCZ 696, which is the trade name Entresto, you take it 100 milligram BID and the patient did take just only 50 a day, that patient did improve. So regardless of the dose, and over a 1-year close follow-up, we showed that there is 43% improvement in New York Heart Classification, regardless of the level of adherence. How about ejection fraction? In fact, I'm proud to say that we were the first group to show in that year that Entresto or LCZ 696 did improve ejection fraction. And again, the ejection fraction improved by 12 points over a year follow-up, which is equivalent to a 49% improvement. And that's regardless of the level of adherence. How about the bigger question? Everybody's saying, well, it is not just morbidity. Do we have evidence on mortality? And that led us to our second work. I'm sorry, so the first is morbidity. Yes, we do have evidence for that, but what about mortality? This is what made us go and follow up these patients for 4 years. So we have 220 patients that we followed closely for 4 years. In this busy slide, I just need to remind you, if you look at the ejection fraction, that if your patient initially did improve with the medication, most likely he will maintain that improvement. The same for New York Heart Classification. And over the course of 4 years follow-up, which is the first of its kind in the Middle East, we showed that the renal function was not affected, the metabolic profile of sodium and potassium was not affected, so that was really good, and for 4 years of follow-up. We published this just 2 months ago. in the Journal of Renin-Angiotensin-Aldosterone System, and we showed the following. Of course, as Dr. Yousef حكى لنا اليوم إنه diabetes in this population was more than 50%. Most likely, it was an ischemic LV dysfunction, accounting for 60% of the patient. Hypertension was more than 50%, etc. What we showed in this study, that these patients that came with congestive heart failure, reduced ejection fraction at time 0, and they did improve, over 4 years, they maintain an improvement of 41% in their ejection fraction, from a mean of 30 to a mean of 41 ejection fraction. The same for New York Heart Classification, decreasing by 1 grade at least, without affecting the kidney function or the metabolic profile. Now, the doses, most of the patients were on 100 milligram BID, total dose of 200 milligram. How about compliance over 4 years? Only 20% of our patients, despite good follow-up, were adherent to our prescription, which is supposedly according to the guidelines. So follow-up of the guidelines, whether by the doctors or the patients, is hard, regardless of how good you think you are. This is an important slide. So it showed that your patient who followed your guidelines or did not follow your guideline prescription and he missed it up, as long as he's taken the medication, regardless of the total dose, whether it is 50, 100, 200, or 400, he will benefit in terms of LV function. And that is at least by an 11 points absolute value. Now, somebody will ask, how about those who took 50 and those who took 400? Is there a difference? And in fact, the numbers were too small to compare them this way. How about New York Heart Classification? The same. Regardless of the dose, whether it is 50 or 400, those patients did get benefit, and overall, they were the same. Now, in terms of dose, as we said, most of them were on 200 total dose a day. What was the mortality in this study? We have a mortality of 15% over 4 years of following around 220 patients. The international numbers were close to 30 to 35, but in fact, you don't have in literature a study that looks at submaximal doses of guideline prescription. So this was a unique study. It was a pilot one to look at submaximal dose over a 4 years follow-up. But in general, before the paradigm heart failure, the range was between 30 and 40% mortality. So yes, using the medication, using the guideline prescription did improve your mortality. Again, I remind you that despite of being good in pushing your patient, educating your patient to follow the guidelines and to follow your prescription, only 20% did that. Most of them were on the partial adherence portion. So in summary, our work showed that with consistent results, that regardless of the degree of guideline adherence, there will be better morbidity and mortality, and that's now evidence-based. And regardless of how good your medical system is, strict guideline follow-up is impossible. Don't think yourself to be an angel or your patient is an angel. It's tough. So in summary, guidelines are great tools for all physicians. Data is clear that following the guidelines will result in better outcome. Unfortunately, as much as these guidelines are valuable, but they are hard to implement fully everywhere, and that's doctor's part and patient part, not always the patient to be blamed for that. Though we should always push for perfectness, but we need to encourage any degree of guideline adoptance, because this is evidence-based that they did improve. So if this makes you feel any better, the term reality disconnect being on paper and in real life does not exist only in medicine. We have reality disconnect in the injustice for definition of refugees. And we have reality disconnect in the injustice of definition of war crimes. And we have reality disconnect in the injustice of defining justice itself. So don't feel bad. Reality disconnect is everywhere. We just need to see it. Thank you.
Good morning. Now, our president of Jordan Cardiac Society, Dr. Abdelfatah Abu Haweleh, he's going to talk about the heart failure in the pediatric age group. Dr. Abu Haweleh is a well-known consultant of interventional pediatric and congenital cardiologist. Yes, doctor.
Assalamu alaikum, Mr. Chairman and Co-Chairman. Thank you very much for your introduction. I will talk about heart failure in pediatric age group. بصراحة احنا بنظلم الموضوع إذا بنعطيه 15 minutes talk. It's very wide and it is common. Some of these are treatable. It is quite different from adult with heart failure. I have no disclosure for this talk, and this is basically the definition of heart failure is a syndrome resulting from ventricular dysfunction and volume or pressure overload alone or in combination. And in pediatric age group, the most common causes are cardiomyopathy and congenital heart disease. This is simply the pathophysiology, as you know, the cardiac output, the preload and afterload, and the contractility. And we have also adverse and good at the same time compensatory mechanism for heart failure. This is the cardiac compensatory mechanism, and we know the earliest and the first sign of heart failure in kids is tachycardia. So increasing heart rate and increasing contractility, then cardiac dilatation, then myocardial hypertrophy, followed by systemic decompensation, and the neurohormonal compensation, which we are depending on modulating the therapy for heart failure in kids. The etiologies are quite different from the adult. And as you know, the heart failure affecting all ages, from the fetal life to the toddler, to the children, to the adolescent, and these are the most important causes. As you see in the fetus, we see heart failure in fetus, in utero, and the severe anemia and hydrocephalus fetalis, the ventricular or atrial tachyarrhythmias. It's a cause, and we see it almost, I will say, monthly. They refer for us cases with hydrops due to arrhythmias in utero. In full term, we shouldn't forget the asphyxia and the sequelae of neonatal asphyxia, the congenital anomaly, and viral myocarditis. In infant and toddler, we see congenital heart disease with shunts, acute hypertension, hemolytic uremic syndrome, SVTs, and Kawasaki. I will focus a bit about Kawasaki because nowadays we have a Kawasaki-like syndrome. It is a MISC syndrome. And we see it a lot. I will say about almost daily I see a case of MISC syndrome, which means that post-COVID, by 3 to 4 weeks, they got a fever, they got a severe inflammatory process, and some of them, they got myocarditis, pericarditis, and so on. If we don't think about this issue and treat them early, they present with a shock-like syndrome and high mortality. And this is COVID. And in fact, the classical investigation we do, of course, clinical assessment, echo, the inflammatory markers, ferritin, CRP, D-dimers, and we send all of them COVID IgG antibody. I had a patient last week who had COVID IgG antibodies 40,000, presented with MISC syndrome. In toddler, we have myocarditis, endocarditis, arrhythmias, and these are the other things almost quite similar. Regarding the structural heart defect, this is the mechanism causing heart failure, afterload, aortic stenosis, pulmonary stenosis, coarctation, preload, VSD, ASD, valvular insufficiency, and most of these cases are treatable. And once you pick them up early and treat them early, the heart failure will improve and they come back to normal life. Of course, the classification, as you know, we have acute, chronic, low cardiac output, high cardiac output, and regarding the location of the heart failure, we have the left-sided, right-sided, or biventricular. In congenital age group, I don't know in adult if it's same thing. We have something called interventricular interaction, which means that if the left ventricular is failing, the other ventricle will fail. This entity, we see it sometimes in long-standing heart failure, and according to the function, the systolic and diastolic, or a new classification, HFrEF classification, we see it. The entity for chronic heart failure, it denotes the ventricular remodeling, which means that there is an adverse structural adaptation of the myocardial tissues with associated changes in the ventricular morphology. Remodeling must be present to support the diagnosis of chronic heart failure. These are changes, permanent changes. And this is why we should treat early in chronic heart failure. And the other thing, they agree as a consensus, at least this remodeling should be more than 3 months to consider chronic heart failure. Clinical manifestation in children, it depends on the age, in fact. For example, in infant, they have poor feeding, failure to thrive, tachypnea, and diaphoresis, and then according to the other ages, this is the figure of the right side and the left side. All of you know these, the differences between the right side failure and left-sided failure. And sometimes we have this very important slide, in fact, acute decompensated heart failure on top of chronic. And the two most important signs is looking at the congestion and the perfusion. And the worst type is the cold and wet. So these are the scenario we see it in acute decompensated heart failure. This example here, if you see very big heart with heart failure, and this is a dilated cardiomyopathy or HFrEF. This is the HFpEF or diastolic dysfunction. In fact, حضرنا محاضرة أول امبارح على الموضوع هذا. Still the HFrEF is underdiagnosed. In HFpEF in adult and even in adolescent, it's underdiagnosed. It's easy to miss. So the clue, the initial clue, is to see biatrial enlargement. Then you send them for detailed echo to label them as a HFpEF. And this is very apparent here, if you see it here. This is the left atrium, the right atrium is almost larger than the ventricles. The other entity, which is, we don't know the cause, it's LV compaction. You see it's a combination of HFrEF and HFpEF, and you see the irregularity of the endomyocardium and the myocardial cells in the LV. You see this is very irregular LV. And this is the gross sample here. You see the LV almost equivalent in irregularity to the right ventricle. The other thing we see, the metabolic group of heart failure, and this is a typical Bombe's disease, second type of mucopolysaccharidosis. They present with a massive hypertrophy. And they have a picture of HFpEF physiology, and usually they have hypotonia. If you see a child with respiratory distress and hypotonia, think of Bombe's disease and metabolic disorder. And this is classical here. You see hypoplastic transverse arch and severe coarctation by CT. And now is coming to the scene in pediatric is to follow biomarkers to assess, to diagnose, and to plan the therapy for heart failure. And these are the classical treatment for heart failure: rest, oxygen, and treating the underlying cause is very important in pediatric age group. If you have a large ASD, large VSD, large BDA, once you close it, they go back to normal. And the ultimate is a transplantation, and this is the line of management of acute decompensation. Of course, we use diuresis more, inotropes, and vasodilators. These are the doses. And this is the optimal approach for acute decompensators, is to recruit the systolic function and adequate blood pressure to achieve decongestion and to reduce lactate production. Thereafter, we recommend gradual withdrawal of pure inotropes, and followed by reduction in a dose of inotrope and vasodilator. Then we introduce, I will say later on about Entresto and the AC inhibitors as a maintenance therapy. And this is the management of just a scheme of how to manage chronic heart failure in kids, depending on the increasing severity of symptoms and worsening of ejection fraction. And these are the category how we introduce the therapy for these patients. Ultimately, you might end by transplant or device therapy. Few words about Entresto, Secopitrel, Valsartan, ARNI group. This is the, you know better than me in this issue. And the most important thing is it has a potential side effect, including angioedema, kidney problem, and hypotension. And there is now evidence that direct introduction of Secopitrel and Valsartan is well tolerated in the setting of chronic heart failure, and this may become a preferred option. This is followed by beta blocker introduction, and this is the approval for children. The FDA approved the use of Entresto in children بأبريل 2019 for patients as young as 1 year of age. And last 2 months, they approved it for kids more than 6 months of age. And the study is well known. It's a panorama study. They treat 110 patients, and they have almost comparable results with the adult. Of course, this is the ultimate therapy for the chronic heart failure. We have patients with the chronic cardiomyopathy, and personally, I have 2 patients with COVID, adolescents with severe dilated cardiomyopathy. And the LVAD, left atrial assisted devices, and in conclusion, the most recent published guidelines from the United States and Canada give recommendations for the management of heart failure in children, provide a recommendation for the management of acute, including diuresis, and for fluid overload, judicious use of inotropes for hemodynamic instability, and AC inhibitors, and now the ARNI groups are part of the therapy plus beta blocker. Thank you very much for listening.
Thank you, Dr. Abdelfatah. Our next speaker, Dr. Mohammad Jaabari, Senior Consultant Intervention Cardiologist at the private sector. He will talk about diabetic mellitus and ACS. Welcome, Dr. Mohammad.
I'm going to explain a little bit about the role of the antiplatelet in acute coronary syndrome and diabetes. Shall we give single or a dual antiplatelet in acute coronary syndrome, and why? Shall we continue antiplatelet for 1 month, 1 year in acute coronary syndrome, and why? Which antiplatelet is the preferable? Is antiplatelet in diabetes differ than non-diabetic? All these questions, inshallah, we will discuss it in this details. About 1 in 5 of acute coronary syndrome patient will suffer with another myocardial infarction, cardiovascular death, or stroke within the first year. The highest risk of recurrent MI will occur initially post-discharge and also continue as in the diagram linear up to 5 years. The patient with history of ischemic event have a continuous risk of a MACE for up to 3 years also. So, what about the post-MI patient? Post-MI patients are also at a high risk for further ischemic event, and they will require appropriate cardiovascular protection. Here, if you see, the risk of recurrent MI was twice higher in non-culprit lesion versus the culprit lesion. The non-culprit lesion, recurrent MI, were more likely to be non-ST elevation MI than the culprit region of recurrent MIs. The life expectancy in a healthy and the one who develop MI, according to Framingham Heart Studies, as you saw all in this diagram, the healthy and the acute MI according to age, regarding whether it's male or female, when you see that the comparison between the healthy and the acute MI, it's divided by the half. So the life expectancy is markedly reduced in a patient who suffer with acute MI rather than the healthy, whether it's male or female. What about the FAST MI study? FAST MI study, as you saw here, in the violet as a non-ST elevation and in the orange as the ST elevation MI, despite the decreased mortality over the years from 2010 to 2015, still the non-ST elevation myocardial infarction mortality rate were not improved. Not also that, while both non-ST elevation MI and ST elevation MI patient are at high risk of recurrent cardiovascular event, non-ST elevation MI is associated with a greater, again, long-term risk than the ST elevation MI with a 2 years rate of follow-up. That's why we give antiplatelet for these patients. And this is the evolution of the antiplatelet from 1980 with the aspirin to 1991 with the teclodepin, 1998 with clopidogrel, and then in 2000 with a dual antiplatelet, in 2009 with the prasugrels, and in 2011 with the ticagrelol. What about ticagrelol? Ticagrelol differs than the other antiplatelet that it's the only B2Y12 inhibition with a direct acting. It's not a prodrug. It does not need to go to the liver to be active. Okay, this is number one. Number two, it's have a dual, the only P2Y12 inhibitors with a dual mechanism of action through inhibition, the B2Y12 receptors and the inhibition of the ENT1 transporter, which induce cardioprotection, modulation of the inflammations, and increase of the adenosine effect, and this is why they develop dyspnea at this area. What about the onset and the offset of ticagrelol? This diagram showed the fast and the greatest inhibition of the platelet aggregation when comparison with clopidogrel. If you see at the beginning, at just half an hour, when you give the patient ticagrelol versus you give him clopidogrel, it will inhibit around, after half an hour, 41% inhibition of the platelet aggregation in the ticagrelol arm versus just 8% inhibition of the clopidogrel. And not also that, after 2 hours of giving this medication, we will see that 88% of inhibition of ticagrelol arm versus 38 only with the clopidogrel arm, which show that ticagrelol provide faster and greater inhibition of the platelet aggregation in comparison with clopidogrel. And here again, if you see the steep elevation after half an hour, and then after that you will see a steepy and a plateau with inhibition of the platelet at 88, almost 89, versus to compare with the 50% only of clopidogrel. And here in comparison, head to head all the antiplatelets, ticagrelol, clopidogrel, and prasugrel. All of us know that. What is the reversibility? What is the active form of it? What about the eliminations between comparison of these three antiplatelet? And here again, clopidogrel and prasugrel. And the important point you should know that when to stop it for elective surgery. This diagram will show you exactly when to stop prasugrel. If you want to stop prasugrel for elective surgery, you can stop it 7 to 8 days before doing the surgery. Clopidogrel, almost 5 to 6 days. Ticagrelol, almost 3 to 4 days, as we show here in this slides. So, in comparison, the efficacy and safety of oral B2Y12 inhibition in acute coronary syndrome, prasugrel and ticagrelol reduce the ischemic event and increase the bleeding in comparison with clopidogrel. A significant mortality reduction was observed with ticagrelol only. There was no efficacy and safety difference between prasugrel and ticagrelol. Also here, in conclusion, with this, prasugrel and ticagrelol reduce again the ischemic event and increase the bleeding in comparison with clopidogrel, but a significant mortality reduction was observed with ticagrelol only. There was no efficacy and safety difference between prasugrel and ticagrelol. So what is the Plato trial done for ticagrelol? All of you know it, but I will go it in a brief. This is a trial of a platelet inhibition and patient outcome study. It's done a large number of 18,000 patients with acute coronary syndrome, mostly unstable non-ST elevation MI or ST elevation MI. It will, with the symptoms onset, they give him 2 arms. We give him Berlenta 90 and clopidogrel loading and maintenance, and we will follow him up with a large randomized clinical trial supporting up to 12 months of a dual antiplatelet, which show and looking for the primary endpoint, cardiovascular death, myocardial infarction, and the secondary endpoint. What's the difference between the arm of the ticagrelol and the clopidogrel group? Here is the characteristics of the study. You see that's almost a smoker, almost hypertension, diabetes, dyslipidemia in both arms, the ticagrelol group and the clopidogrel group. And the medical history regarding MI, percutaneous interventions, non-hemorrhagic stroke, peripheral arterial disease, chronic renal disease, it's important. And here show that around 60% of the Plato populations are mostly non-ST elevations, MI, and unstable angina. Show that Berlenta ticagrelol 90 reduced the relative risk reduction early and over the 1 year versus clopidogrel with a relative risk reduction 16%, and not that only, it's the beginning of the reducing the relative risk reduction. It's from the first month with a 12% reduction in the ticagrelol group versus the clopidogrel group regarding Lalme's cardiovascular death, MI, stroke after 1 year. And here again, ticagrelol reduced the relative risk early over the 12 months in comparison with the clopidogrel group. Here again, regarding LAL mortality, ticagrelol reduced almost cardiovascular mortality significantly within 1 year in comparison with clopidogrel with relative risk reduction at 21%. And again here, regarding the myocardial infarction, after 1 year in ticagrelol groups with a relative risk reduction 16% in comparison with clopidogrel group. What about the non-ST elevation patients and using ticagrelol? In the non-ST elevation patients, it's also show a benefit with a reduction, relative risk reduction in the ticagrelol group comparing with clopidogrel with a relative risk reduction 17% in comparison with clopidogrel. And here it's very important slides regarding the antiplatelets with renal impairment. If you see, if the GFR of this patient at the creatinine clearance is almost 90 or 100, the benefit between ticagrelol and clopidogrel almost the same. But when the creatinine clearance become lower, 60% such as an example, is or a 40 or a 30, you will see in this that the ticagrelor is better than the clopidogrel group regarding to a cardiovascular death, MI, and stroke. And here again regarding the stent thrombosis, which show that Brilinta show reduced benefit stent thrombosis at 12 months comparing with the clopidogrel with almost 33% in comparison with the clopidogrel and aspirin. And here again, ticagrelor demonstrate no increase in overall bleeding or a fatal bleeding in comparison with the clopidogrel. Again here you see the major bleeding according to Plato, Latemi, the major bleeding in comparison ticagrelor versus clopidogrel will show a not significant p-value as a secondary safety endpoint in non-cabbage related major bleeding and the cabbage related major bleeding and the major or minor bleeding, it show no difference between ticagrelor group and clopidogrel group with a non-significant p-value. What about the dyspnea? The dyspnea in ticagrelor versus clopidogrel, as you see here, the incidence of dyspnea in ticagrelor group show almost 13% in the arm of ticagrelor in comparison with the clopidogrel, which show a 7% with a significant p-value. Patient who discontinue treatment due to dyspnea, it's 0.9 in ticagrelor group and also in clopidogrel group just 0.1. Relating the dyspnea, and I always tell our colleagues that don't stop ticagrelor just for a dyspnea. Make sure that the dyspnea is related to these drugs, because the patient will not die from the dyspnea, he will die from another myocardial infarction or another stent thrombosis. So how to approach for the dyspnea in ticagrelor? Number one, in a patient with a new onset dyspnea, the history is very important. Most of our patients are COPD patients or heart failure sometimes patients. So physical examinations remain the mainstay for the diagnostic criteria for the dyspnea. Number two, assessing cause of dyspnea may be difficult in acute coronary syndrome. Dyspnea is very common with ticagrelor, more than 10%. Acute coronary syndrome response to dyspnea has a high risk profile and should be managed with the most effective treatment. Balancing the side effect and the proper importance of the ticagrelor is very important, so don't stop ticagrelor related just for the dyspnea. Make sure that the dyspnea is related to these drugs. And here show that the benefit of ticagrelor in acute coronary syndrome in elderly patient, in diabetic and CKD patient. What about rapidly the de-escalations? De-escalations might be safe, but it associated with a high risk of ischemic event as compared with ticagrelor. So the de-escalation between Brilinta or ticagrelor to clopidogrel increase the platelet reactivity. What about the guidelines? All the guidelines show in ST elevation and non-ST elevation patients, a potent P2Y inhibition, ticagrelor, prasugrel, or clopidogrel, if they are not available or are contraindication, is recommended before or at least at the time of the PCI and maintained over 12 months. This is a class 1 indication unless there are contraindications such as excess risk of bleeding. This is in ST elevation, it's class 1A, and also in non-ST elevation MI, it's a class 1 also. Here the European and American guidelines show the benefit of using the antiplatelet for the duration of a dual antiplatelet in acute coronary syndrome, whether you will treat him medically or invasively, regarding the high risk of bleeding. If no or yes. If no, in a medical treatment, the European Society show that it's a class 1 indication, 12-month ticagrelor preferred over clopidogrel, and also the American. What about the PCI with high risk of bleeding? If yes, the European and the American show that it's a class 2A. And here the last slide, what about the recommendations of the European in 2019 in your recommendation that prolong of dual antiplatelet beyond the 12 month should be considered for up to 3 years in a patient with diabetes at a very high risk who have tolerated of a dual antiplatelet without major bleeding complication. And thank you so much.
Thank you, Dr. Mohammed, for nice review on ACS and dual antiplatelet in diabetics and non-diabetics. The floor is open for questions and comments for all speakers.
أنا عندي كومنت. مثلا بعد صباح الخير جميعا. صحيح دائما نحكي بالعربي، ناخذ العصا من النص. لما يجي المريض على الطبيب لازم نحكي بالتثقيف الصحي. يعني شغال. التثقيف الصحي لازم احنا كجمعية اطباء القلب من وجهة نظري نعطي جايد لاين للناس العاديين كيف تتعامل مع السكري، كيف تتعامل مع الكذا، عشان نعرف هو شو وضعه قبل ما يجينا وقبل ما يجينا مراحل متأخرة. وهذا الشيء اعتقد مطلب منا كجمعية اطباء القلب نطلع اشي بالعربي للمواطن العادي مش للاطباء كيف يتعاملوا مع هاي الارقام ويتعاملوا معها، لانه التثقيف الصحي مهم جدا. الجزء الثاني التأمين الصحي. التأمين الصحي الأردني هون أنا تعاملت مع شركات تأمين مع الضمان الاجتماعي بحاول ياخذوا التأمين الصحي مع وزارة الصحة، مش راضيين يقتنعوا إنه إذا أنت تحكمت أو سيطرت على 100 مريض بكلفوك أقل من كومبليكيشن واحد لمريض ثاني. فإذا احنا اشتغلنا بهاي العقلية ممكن نخفف من الإصابات والمرضى وتوابعها. يعني التأمين الصحي مثلا بيعتبر عندك سكري، إذا صار معك تشست بين هاي مضاعفات السكري، هذا الشيء خطأ. التأمين بوزارة الصحة الانترستو بعطيه فقط الحالات الأدفانس، بعطيهوش لكل حالة. يعني الحالات اللي بتحتاج ما بتاخذها إلا كان مواصفاتها أدفانس. فإحنا بعتقد لازم كجمعية أطباء قلب وأطباء قلب موجودين هون نحكي بهذا الموضوع، نطلع بقرارات إشي توجيهية لهاي الناس عشان نعرف كيف نتعامل معها. يعني أحكي لكم بالتأمين الإلزامي للسيارات إذا بتسوي حادث بتدفع أكثر. لو شركة التأمين إجا واحد عنده سكري قالت له كل 3 أشهر كل 6 أشهر سوي فحص تراكمي، إذا أنت تحت ال6 أنا بعاملك مواطن عادي، كل ما زدت أكثر بدفعك تأمين أكثر. شو ردة الفعل راح تكون؟ فحص الدهنيات عندك، إذا أنت بتجيب لي إياه بمختبر أنا أعتمده وكل مرة أنت مضبوط ملتزم، شو راح أسوي أنا؟ أعتقد هيك راح يكون توجه تأثير إيجابي عند كل الناس اللي تورد انهم يسيطروا على مرضهم ويخففوا من الكومبليكيشن الموجوده عندهم، واسهل لنا للدراسات والمتابعات. وشكرا لكم على الاستماع.
دكتور مصطفى.
السؤال للدكتور هادي. شكرا على محاضرتك in regard to guidelines on prescription of anti-lipids. The last 20 years has witnessed great advances in the and accumulation of data on the prescription on treatment of hypercholesterolemia or dyslipidemia. Three main categories now are clear that we know when to prescribe, like those with atherosclerotic cardiovascular disease, those with high LDL more than 190, and diabetics between 40 and 75. But the fourth group, 40 up to 75 years, the ACC calculator of risk, 10 years risk, comes to ask to answer the question when to prescribe, even if the level of the cholesterol is normal. But there are still many subgroups lie in the gray zone, and we are hesitant to prescribe. But another definite group is when somebody as a male becomes older than 55, or a female above 65, even if her cholesterol is within normal limits, the calculator tells you that the 10 years risk is above 7.5, and those patients definitely deserve statin. But the recent data on the CAC exempted those with the zero calcium score above 55 years, according to the calculator, they have 7.5 10 years risk. According to the CAC, they don't need, they can be exempted from statin. Do you think we have to modify the calculator or?
Not really. It's a very good question, actually. When you look at the calculator, is it on? When you look at the calculator, Dr. Mustafa, the 7.5 to below 20, هذول هم intermediate risk. هذول you need risk enhancers for them to prescribe.
Between 5 and 7.5, you need enhancers. Above 7.5, you need to prescribe.
Not really. I mean, not for the primary prevention purposes. 7.5 to below 20, those patients you need to consult with them, explain to them the benefits of the statins, etc. Risk enhancers make your recommendation stronger for sure. Well, risk enhancers مصطفى كثار. يعني أنت when you think of it, there are a lot. يعني the mere presence of an LDL above 160 is a risk enhancer, consistently. A triglyceride of above 150 all the time is a risk enhancer. بتلاقيهم كتير. I'm not quite sure. The coronary calcium score is a beautiful tool, no question at all, and it can work for 55 and above, Mustafa. However, the problem with it, when do you want to order it, and how do you benefit from that in prescribing statin? مش لكل المرضى. It doesn't work for everybody. It does not.
دكتور إياس.
دراسة أنا شفت إنه the partial adherence للأرني still translated into positive outcome. بس كيف could you differentiate الadherence ل other medications؟ المريض ماشي على others adherent بس the ARNI is not adherent. Would that يعني make the conclusion less reliable? How could you differentiate? Did you look specifically مثلا المرضى أخذوا ARNI at different doses مرة أو مرة لا for cost, but they continued to be on other guideline derived medical therapy يعني beta blockers و MRAs و SGLT2 مثلا؟ واضح السؤال صح؟ طبعا هشوف الجواب إذا واضح.
Thank you. Yes, we looked at that. In fact, it is for all medications. The partial adherence was for all medications. And we were surprised that despite we stress on taking all these medications on time, that there was poor adherence. We were glad at the end of the study that it is partial, that they did not stop the medication. So to answer you, yes, we looked at that. It's across the whole spectrum of medications, and mainly it was for cost, to tell you the truth. Very little of our patient population stopped because of side effect profile. Most of them were related to the cost. And as الزملاء حكوا إنه حتى لو عندك medical insurance system that works very good in Jordan, still patient will have some kind of cost, and الحكومة cannot support all the big junk, the big share of congestive heart failure reduced ejection fraction. Excellent question, yes, thank you.
وأنا عندي سؤال للدكتور رائد. يعني لأنه this is very important what you have presented. إذا ال 50 milligram of ARNI gives me a 12 points improvement in the ejection fraction, وال 400 أعطتني 13 points. And this may change practice or may change the guidelines. Why I should go to 400 milligram of ARNI if I'm getting the same benefit with partial adherence?
Yes, Asim. I think this is one of the conclusions we came for. Now, we don't have an evidence to stress that on all the patients. So what we can say at the end of those studies that you need to convince your patient to be on the guidelines. Most of them will not. Don't feel bad, and don't make your patient feel bad. Whatever dose he's on and he's happy with, just continue. But we cannot at this point of time tell the company and tell everybody, well, listen, I got 50 milligram dose giving you the same benefit as 400. Why should I go to the 400? We cannot have that conclusion because the numbers were small. Thank you.
Sorry, yes?
in the audience يعني إنه 50 is as good as 400. Paradigm كانت many thousands of patients. فبدناش to jump to conclusion إنه مريضنا بده بس ياخذ 50 مرة باليوم is fine. بالبارادايم اطلعوا على الناس اللي أخذوا الفول دوز قليل أخذوا الفول دوز. بس if you achieve suboptimal dose you still have benefit. بس مش as good as the full dose. The message has to be إنك you want to push the dose as maximum as possible. بدناش يعني suboptimal نص كم treatment just because we think we save cost. فبلاش يكون conclusion يعني على الأقل الجونيور audience ما يكونش misleading.
Yes, I think the point that Iyas is making is very important. We need always to stress to go for the guidelines because it is not just one study. We have multitude of studies showing that follow the guidelines, you get better results. So the message that we are trying to convey here, push for the guidelines, try to convince your patient to go for the guidelines, but do not feel so bad if your patient said, I'm not going to be on your guidelines like 100%. Just keep on, encourage him as much as he can tolerate, do it.
In 5 years, you're giving us a 15% mortality in 4 years. That's really unheard of. So, I mean, the numbers really are impressive, but I don't know how close to reality, because if we manage to drop a mortality from 50 to 15, I mean, that's heart failure is curable at this point.
Okay.
If that's what you are telling us.
Yes,
Thank you.
well, let me correct what you have said. So literature is saying that you have 50% mortality at 5 years, that's before the paradigm heart failure. Follow-up studies that were done showing that that mortality of 50 in the international studies reached down to 30. But nobody so far has looked at every year what's the mortality up to 4 years. These studies are coming. So yes, you're right. Heart failure is getting better in terms of mortality and morbidity if you follow the guidelines. Don't get surprised. The number 15 to 30 will be the magic number you are going to see from now on. That 50% 5 years is not true anymore. Look at your patient population in your clinic. You will notice that there is improvement. Follow the guidelines, push as much as you can, and most likely the numbers might not be as low as 15 as we found, but most likely it will be in the range of 15 to 30%.
ويعني التوبيك تبعه للدكتور رايد كان disconnect from reality. يعني he really disconnected us from reality with the data he presented. But يعني well done والمسج يعني وصل الدكتور ياسك. I wish there were BNP levels done in these patients يعني to see where those patients who improved had a low BNP or did it guide your therapy?
Yes, indeed, we do. We do have a certain number of the patients underwent the BNP, and most of those showed that improved BNP will correlate with symptoms. We do have that data. The second thing I need to mention here, in our studies, we found an effect of sawtooth ejection fraction. You cannot imagine that patients who are on 50 milligram a day taken Entresto, they will feel better within the first week. Ejection fraction will improve between the second and fourth week. And if that patient kept on guidelines, ejection fraction will be better. If he stopped due to any reason, it will go down, and you convince him back again to take the medication, it will go up, a sawtooth appearance. We notice that in our patients.
Do we have more time? Okay, Dr. Mustafa, yes, please.
Let's not forget that in the early 90s that the only treatment was available for those patients with the severe LV impairment is cardiac transplantation before introducing ACE inhibitor, the first study with the captopril. Since that time we started to see decrease in mortality, and at that time we had only diuretics and digoxin, which do not have any impact on mortality. Only their only impact was on morbidity, but not mortality. But since they started to accumulate data on those drugs which have impact on mortality, like ACE, ARBs, beta blockers, mineralocorticoid antagonist inhibitors, and recently SGLT2 inhibitors, of course we would expect massive decrease in mortality.
يعطيكم العافية. أنا دكتورة أسماء حامد استشارية طب أسرة. حبيت أشكر الدكتور علي النقطة الجوهرية اللي بدأ فيها الكومنتس إنه we play a crucial role as family doctors أو frontline service أو primary care providers. موضوع الكوميونيكيشن سكيلز وقصة الادهيرنس هذا موضوع لحاله. فالبوليفارماسي المريض most likely اللي بيكون عنده comorbidities بيكون عنده ممكن أنا I have patients who have 15 medications. فالادهيرنس we would like to preserve your precious time as cardiologists. نفعل دورنا احنا اللي هو الكوميونيكيشن سكيلز it's an art. انه الاشي اللي احنا ما بنقدر نعمله كفاميلي دكتورز انه انت you spare your time for details of the details and for interventions and for cath and for others. بيجي دور هون الفرونت لاين سيرفيس بالeducation. It's not an easy thing. We have to tailor the management to the level of the patient. فهي بتعتمد كلها على الكوميونيكيشن سكيلز. قبل ما نوصل هارت فيلير في to control hypertension and diabetes. It's not an easy. مريض ما بيكون لحاله hypertension diabetes بيكون asthma with its medication, psoriasis and its medication, asthma and its medication, diabetes, many things. فهي هاي it's a skill, it's an art. فشكرا كثير دكتور يعطيك العافية.
شكرا للجميع. و I think we're gonna move to second session.